Right, okay, looks like we started recording. Welcome everyone to Reading's Health and Wellbeing Board. Thank you very much for joining us today. My name is Graham Hoskin. I'm the chair of the board and the lead counsellor for health, wellbeing and sport. We have lots and lots of people here, so I will ask when people do speak if they could introduce themselves at that point so everyone knows who is who. And it's not easy in these so getting fed up now with online meetings and very much looking forward to when we can all meet again in person. I've got a fairly well, you've probably all heard this before lots of times, but an announcement that relates to online meetings, so I'm going to read it out. Sorry it's so dull. This is my chair's announcement. I'd like to inform everyone present that this meeting will be recorded in Microsoft Teams, and we're recording now, and then be uploaded and available for repeat viewing on the council's website. Councillors, officers and partners attending will be asked to introduce themselves before they speak at the meeting, so for the benefit of the public. To help me manage the meeting, if any members of the board wish to speak during the meeting, please can you indicate your wish to speak in the chat section of your screen and then wait to be called, unless we're always talking over each other. When not speaking, all attendees should put their microphones on mute and switch off their cameras. Then when called to speak, please switch on your camera and unmute your microphone and pause for about a few seconds to allow for the slight time delay in connection. If you're addressing the meeting, it would be best if you can have your camera on so that people can see who's speaking. However, we are aware that with immersive individuals, broadband services, so it is possible that loss of connection may happen, or if your connection is poor, you may find it improves if you turn your camera off, and we'll understand if that is necessary. Okay, let's crack on then. So I know it's not on the agenda, but have we got any apologies, Nikki?
Yes, Chair, I've had apologies from Deborah Glassbrook, Kate Reynolds and Nick John, also Paul Illman and Gail Muirhead from the Fire and Rescue Service. I think that's all, but do shout if there's any others.
Okay, thanks. Well, I've got an apology. I need to be off at around about 3:45 because I've got a COVID vaccination appointment I'm going to go and rush off to. Dr. Andy Cichurski, my vice chair, is ready and waiting. Will take over seamlessly at that point if we're not finished by then. Okay, so the first item is declarations of interest. If anyone's got any interest that they need to declare of any of the items coming up, declare them now. And if it occurs to you during the meeting you've got an interest, then declare it at the earliest possible moment during the meeting if it suddenly occurs to you when we're talking about something. Okay, so the second agenda item is the minutes of the meeting held on the 22nd of January. Hopefully everyone's got access to them and has been able to see them. I'm not going to go through page by page. There's a lot of pages. It was a very full meeting. Has anybody got any either points of accuracy or anything they want to raise off them that we need to address? Now is your moment to speak. In which case, not seeing anyone indicating, we'll sign those off as a true record. And then we go straight on to the questions. And we've got two questions from Mr. Tom Lake, who is sitting there patiently waiting to ask. Mr. Tom Lake, fire away.
Thank you. Apologies for the length of this question, but it is an intricate matter. And I'm Tom Lake, Information Officer of South Reading Patient Voice and an elected governor for Reading at Berkshire Healthcare. Now, the recent NHS white paper envisages statutory reshaping of integrated care systems such as the BOB ICS, including absorbing the functions of CCGs. And Section 511 states the ICS will also have to work closely with local health and wellbeing boards as they have the experience as place-based planners. And the ICS NHS body will be required to have regard to the joint strategic needs assessments and joint health and wellbeing strategies that are being produced at health and wellbeing level and vice versa. ICSs will also want to think about how they can align their allocation functions with place, for example, through joint committees, though we're leaving this to local determination. NHS trusts and foundation trusts will remain separate statutory bodies with their functions and duties broadly as they are in the current legislation. Now, at present, the detailed knowledge, resource and skill to be a place-based planner for health resides with Berkshire West CCG rather than with the Reading Health and Wellbeing Board. If the Reading Health and Wellbeing Board or the grouping of Berkshire West health and wellbeing boards are to take on the role of place-based planners of health. A completely new level of working with NHS capacity, usage and finance data will be needed, as well as close cooperation with the main NHS providers for Reading. How do you foresee the Borough Council taking on these new functions and resources?
Thank you, Jack. There's also a bit about the Health and Wellbeing Board for GPs as well, but I'll answer that within the question. So thank you, Mr. Lake, for your question. First of all, we do need to remember that we are still talking about a white paper, which is a report that lays out the government's proposals for future legislation. And whilst there may be things we like and don't like in the white paper, we'll have to await the government's first draft of legislation and further guidance to get a better understanding of more specifically what the future reorganisation of the NHS will look like. The Health and Care White Paper sets out proposals for future partnership working between the NHS and local government through integrated care systems. The stated intention is that local authorities will be involved in both the ICS NHS bodies and ICS health and care partnerships to support health and social care integration and encompass preventative approaches. The ICS NHS body will take over the functions and funding to the CCGs and will be able to delegate funding to place level. The ICS health and care partnerships will have responsibility for developing a plan to address the system's health, public health and social care needs. Further national guidance is expected on how the new ICSs will operate, including how to align partners' practices and cultures. However, there is local experience of collaboration and planning, which we'll be able to draw on in Reading. For example, the production of a joint strategic needs assessment and a joint health and wellbeing strategy is currently a shared responsibility of the CCG and the local authorities through the Health and Wellbeing Board. Through these functions, and also from our experience of collaborating on better care fund plans, Reading Borough Council has established a strong foundation for collaborating with the NHS to share data and expertise. Reading is currently working with our Berkshire West neighbours on the production of a new health and wellbeing strategy. This aims to recognise cross-border travel and use of services within the Berkshire West area, will also reflect in the particular issues relevant to each of the three boroughs. In addition to the feedback gathered through the recent public engagement exercise to shape the new health and wellbeing strategy, there is additional feedback we can draw on regarding local views on place-based planning for health. The CCGs within the BOB ICS established an architecture oversight group, which oversaw an engagement exercise with a broad range of stakeholders towards the end of 2019. Through this exercise, people were invited to comment on how different structures would support delivery on commitments in the NHS long-term plan and provide appropriate oversight and accountability, and takes advantages of opportunities to share expertise and resources through organisations. These will remain important considerations in designing the new ICS for this area. Our own Health and Wellbeing Board does, of course, include strong GP representation in the form of our Vice Chair. The question also refers to new joint committees, which are referenced in the white paper, and suggested members of these committees include primary care networks and GP practices, as well as community health providers, local authorities and voluntary sector representatives. Again, further detail is awaited from a national level on how these will operate. So, Mr. Lake, do you have a supplementary?
Thank you. In this case, I do. And it's just that this Architecture Oversight Board is complete news to me. And there's someone who follows the public presence of the CCG and tries to follow Bob. I must say it's quite a surprise. I wonder if, in accordance with the NHS Constitution, the public might be properly involved in this matter.
Yeah, it's a good point, Mr. Lake. And as the plans, I think, the white paper throws in a whole range of further considerations in terms of planning, and we need to think about how we bring the developing plans of the ICS to the public of Reading. That may be through the Health and Wellbeing Board. It may be through a scrutiny committee.
Thank you.
Thank you, Mr. Lake. Right, you have another question.
Indeed. OK, after the fiasco of the tender for primary care services at Circuit Lane and Priory Avenue, which was won by one medical group, the local CCGs issued no further such tenders, but they've worked to encourage GP practice renewal through consolidation, through mergers and through bringing in new partners and encouraging practice development with very positive results. Now, after the dissolution of Berkshire West CCG, how will such detailed and constructive oversight be maintained?
Yeah, thank you, Mr. Lake. I'm going to, this is an NHS function, I'm going to give you the response provided for us by our NHS partners. I will say, for my own part, one of the things that we are pressing very, very strongly with our NHS colleagues is to maintain the close local relationships and the close local working, such as that which was demonstrated when we had to unpick some of the problems that occurred through the Circuit Lane and Priory Avenue commissioning, and actually working together with, for instance, local councillors, local representatives of the council, and actually patient representatives, we got to a better result. So that's something that we're pressing very strongly as we move towards a wider planning area of the Buckinghamshire, Oxfordshire and West Berkshire BOB. So, but the response is that we have is that NHS providers will be reviewing arrangements for the delegated commissioning in primary medical services as part of the further development of the ICS. This work is still at an early stage. However, it is intended that decisions on local primary care services will continue to be made at place level and with the continued involvement of appropriate stakeholders. You have a supplementary, Mr. Lake?
No, thank you. Thank you for that response.
Thank you. Thank you very much. Right, that's we have no further questions, in which case, in my little pile of papers, I'll try and find the agenda again. Here it is. I don't think we have any petitions, do we, Nikki? No, that's good. So the first main item we've got here is the impact of COVID-19 in Reading. This is a slightly more focused item than we've had previously, because we had the Outbreak Engagement Board only a few weeks ago. So it may be slightly different to we had in previous health and wellbeing boards. So I'm going to hand over to David Monday.
Thank you, Chair. And so my role is to go through just some headlines of the latest kind of data and COVID situation in Reading, and then I'll pass on to colleagues from education to update on the schools return, and then I think to NHS colleagues in terms of primary and secondary care services. So as you say, a fairly focused item, so I'll deliberately be brief, but happy to take comments and questions at the end of the kind of presentation item. So Nikki, could you move on to the next slide, please? Thank you. So this data, so those members of the board and particularly through the local Outbreak Engagement Board as well, will be fairly familiar with the way that we measure the case numbers regarding COVID for Reading. So within that green column that you can see with just the one yellow, that's where we're measuring the positivity rate for COVID-19 in Reading. So that's of people going for PCR tests, so the lab-based test if you have symptoms, the proportion that come back with a positive result. And the latest number for Reading is actually 1.2%, so it's dropped from the 1.7% from when these slides were put together. So that has been continually dropping over the last 2 months. And then the next column is our case rate per 100,000 of population. And that number, again, has fallen a little since these slides were put together and currently sits at 34.6 per 100,000. So we are seeing a decline where the rate of decline is now slowing, as you might expect. We were at about 800 per 100,000 up in back in January time. And you can see then where Reading sits in terms of its position against other Berkshire authority areas as well. So if you go to the next slide, please, Nikki. So we segment data on case rates in Reading in a few different ways. This is segmenting it by age. So it's the same case rate per 100,000 that I just was referring to, but this time, as you can see on the y-axis, so that's the axis on the left-hand side of the table, you can see the different age bands listed, and then over a 4-week period, what the case rate has been for that specific age band. And really, what this shows us is that for Reading, the reduction that we've seen has happened across the across all the age groups. When we segment by ethnicity, again, we see the same trend where we've seen a significant decrease across all ethnic groups. And when we segment by geography in Reading and look at particular wards, again, we don't have any wards which have a alarmingly high rate of COVID compared to the Reading average. So that reduction that we've seen is very much kind of true across the board. If we move to the next slide, please, just to give you a sense of the kind of trend over time, and again, the comparison to other parts of Berkshire, you can see kind of centre at the top is the Reading graph, and the Reading specific rate is the blue line, whereas the grey and orange are South East and England rates. And you can essentially see that for Reading, the decrease occurred a little bit later than average for our region or nationally, but then has fallen dramatically down to the same rate as is being seen at a kind of a larger geographical area, and a fairly similar story across Berkshire, with probably West Berks and Slough being the two kind of more extremes of the spectrum of what's happened with case rates. And then if we move on to the next slide, we obviously continue to monitor the numbers of deaths that occur locally closely, and we have data on that comes through every week. And what you can see is that the amount of blue in this graph is becoming less. And there's an additional week, which again hasn't made it onto this slide, which showed just 2 COVID deaths in Reading in a week. Clearly 2 more than we want to see, but we are definitely seeing that reduction in COVID-related death, which of course we expected to see as we started to see the case rates fall. And then if we move on to the next slide, please, Nikki, I just wanted to give the summary. We're not going to go into the detail of this today, but we've all seen the roadmap from the government in terms of the release from lockdown. So just to touch on this briefly then, so we know that we're in step 1 at the moment, and on the 29th of March, the main change will be that the rule of 6, or indeed 2 households, can meet outdoors, and outdoor sport can restart. And then in step 2, which we hope to be on the 12th of April, but clearly await kind of confirmation of that, we would see probably the greatest change being that all retail can be open from that point. Indoor leisure centres can be open, and then the kind of outdoor hospitality. And then on the next slide, we've just got steps 3 and 4, which are projected to be in 17th of May and 21st of June. But again, obviously, as we all know, I think we wait to hear the definitive timing. And in step 3, we see that indoor hospitality reopening and the rule of 6, or the 2 households, moving to an indoor permission. And then step 4 is where we see a significant amount of restrictions removed. So there's obviously far more detail that could be said about that, but it was just to give that kind of summary of where we're at with the lockdown release. If we move to the next slide then, so clearly one of the key ways that we can ensure that happens safely is about having effective vaccination rollout locally. Before we talk about that kind of local part, clearly there's been a lot of media coverage and a lot of interest regarding vaccination in the last few days, particularly vaccine safety, and the European countries that have paused use of the Oxford AstraZeneca vaccine. So kind of worth pausing here to be clear that we are in a on a review of the data, the UK position and the European position, and clearly our view kind of locally in Reading is that the Oxford AstraZeneca vaccine is safe and it's effective, and we're not seeing a higher level of blood clots within the vaccinated population than would naturally occur, because we know that it is a phenomenon that occurs reasonably commonly in people. So, very confident in the safety and the effectiveness of that vaccine. I've spoken at this board before about the different ways that we're delivering the vaccine here in Reading, and I'm not suggesting that we can go through that in detail at this point. What I will do is just highlight that the primary care network sites continue to work very effectively in reaching the local population. The hospital hub sites that we've had for the social care and health staff are being stood down for, they will complete dose 2s and then will be stood down, and they have delivered thousands of vaccines to our workforce, and any new people that join the workforce going forward would be vaccinated via the mass vaccination service. So those services will be stood down when they've completed their dose 2 work. The number of pharmacies in Reading delivering vaccine will increase in the coming days, in the coming weeks. We've got the Triangle Pharmacy currently, but there'll be 2 further pharmacies that come on stream, we expect, in Reading in the near future. And clearly the Medeski Stadium is doing that kind of mass vaccination role. So that's the kind of delivery kind of mechanism. On the next slide are the cohorts of those eligible for vaccination, which we're all familiar with seeing. So since I put this slide together, we've now a cohort 7 should be turned to green, actually, because those vaccination of those of those aged between 60 and 64 is by and large complete in terms of that offer to the age group. And the invitations and the work within the mass vaccination arena is currently with the those between the ages of 50 and 59, and the primary care networks are finishing off the work on offering the vaccine to all of those under the age of 65, but that have a long-term health condition that mean that they're a priority for vaccination. Now, clearly, the other media headline in the last day or 2 has been around vaccine supply, and what we understand is that there will be a pausing. Quite a fairly short pause, but there will be a pausing of the vaccination program once the Group 9 are complete, before we move to the under 50s. So we're waiting for the detail of what that means in terms of exact dates, kind of for Reading. But that was obviously announced nationally, I think, on Wednesday evening, that there would be that short delay. I think it's worth noting for the board that we know that 99% of the preventable mortality from COVID-19 occurs in those priority groups 1 to 9, which is why they've been prioritised for vaccination. So whilst we wouldn't choose to see a delay in rollout to those aged under 50, it doesn't put our local residents at an increased risk. It's not a major threat to us in Reading, but clearly something we want to see addressed, and we want to move forward with vaccination for everyone aged over 18. So then the last thing on vaccination, I think, is on this next slide, please, Nikki, just shows you some of the numbers in terms of vaccination. Now, just because of the timing of when data comes out, there's actually 2 weeks more worth of data than what's on the slide here. So the number of people vaccinated in Reading is almost 45,000 now. So that's a significant effort in a relatively short period of time. When I checked the kind of unverified but data that comes through from the NHS in terms of uptake rates from the kind of primary care records, what we're seeing is both a high uptake rate within Reading. So uptake is between 85 and 93% when you look at those aged 65 and over. And there is a little bit, but not much variation between GP practices across the town. And when we compare that to flu vaccination, which we annually offer this same cohort of people, we're seeing a much higher uptake than we see in flu and much less variation. So I think that's really positive news. Where there is any variation, and we are seeing pockets of lower uptake in vaccination, this short pause in rollout to groups, priority groups 10 and beyond, gives the NHS, local government, voluntary sector and other partners that are working together on this the opportunity to do more on the on making the vaccination offer as accessible as possible. And certainly work's going on with an inequalities subgroup within the NHS to ensure that happens, and looking at developing pop-up clinics and local offers to ensure that vaccination access is as easy as possible. And then the final slide from me, if you can just move on to the last one, please, Nikki, is just on lateral flow testing. So again, I've spoken at this board and also at the Outbreak Engagement Board about this. All I'll kind of touch on is that in terms of the changes that have occurred since the last time, is that we are now encouraging the household of school pupils to have twice weekly lateral flow testing, and they can obtain those kits from the community collect service, which currently is via our PCR swab testing site, so London Road and Prospect Park, and then pupils themselves, so secondary age pupils, this week moving from testing in schools, having had their third test in schools, to twice weekly testing at home. So that's the kind of the movement that's happened there, and we have opened up our council-run community testing centres, so the one at South Reading Leisure Centre and at Rivermead, to all workers or in Reading who are unable to be working from home and need to be kind of out of home for work, are eligible to go and be tested again twice a week. And this is all about trying to ensure we pick up cases of COVID which otherwise would go undetected. So that's everything from me. As I say, I'll pass on to schools colleagues and then on to NHS colleagues, but happy to take any comments or questions after that, Chair.
Great, thank you, David. Yeah, if we take questions, comments at the end, I think we can get through this. So, schools overview.
Hello, I'm Jill Dunlop. I'm the Pupil and School Service Manager, and I'm representing Kate Reynolds in this meeting.
Thank you, Jill. Thanks for coming.
Nikki, can I have the first slide, please, the attendance slide? Okay, this is the data. Oh, sorry, there was data from the. Nikki, have we got further data down from the 17th of March? Lovely. Sorry, I hadn't had a chance to look at the slides. From the 17th of March, you can see from the 8th of March. Sorry, Nikki. We start at the top again. So you can see the data from the 8th of March about the percentage of pupils on site. It's compared with England. So in terms of our primaries, we had 90. I'm trying to read this off the screen now because I haven't got my 95.7% primary, and sorry, let me go back to this. This is the comparison with weekly attendance compared with England, Reading, South East and statistical neighbours, and you can see from that Reading was 85%, which is above the England average for the start of school on the 8th of March. So again, we've been talking with the DFE, and the DFE are very impressed with the Reading with the Reading figures. Next slide, please, Nikki. Again, we've got the early years summary for the week starting the 8th of March, and the Reading figures are 18.4%, and you can see again that we are above our neighbours, the England total and the South East statistics as well. So Reading are doing really well in terms of getting their children back into school. This is the latest information that we've had, and I think the Reading schools, the head teachers and their staff have managed the return to school from the 8th of March really well. They've done an extraordinary job all the way through COVID, but getting the children back into school was something that they were really looking forward to doing. So you can see there's been an increase since the 8th of March. So our total figures for all children on site on Wednesday was 93.1%. And for primary schools, it was 94.4. For the pupil referral unit, it was 63.3. Secondary schools at 91.3, and special schools at 84.9. We haven't got a comparison yet against the DFE, but I've just been looking at an email, and on the 15th of March, the government whole figures for the whole of England were registered at 89%. So Reading again is ahead of England attendance figures, standing at 93.1% for the whole of the cohort. So again, great effort from head teachers and all the people supporting our children to get those children back into school. And I'm thinking about social workers, education welfare officers, and everybody that's supporting children and families. So great effort from parents and everybody to get those children back into school. You can see from the figures at the bottom that in terms of our children that are eligible for free school meals, 87% of those children were on site on that day. The next circle along is the children with education healthcare plans. 84% of those children were in school, and for children with a social worker, 81% of those children were in school. In conversations with the DFE, I think I might have mentioned this, the DFE are very, very impressed at the efforts that our schools have gone to, all our services have gone to, and the statistics in terms of attendance for Reading. So we're very proud of the work that we're all doing to achieve that. Nikki, I think that is the end of my slide, is it? Yeah, so I think I've mentioned this as we've gone through. So all our primaries were open from the 8th of March. Mandatory attendance is now requested. Secondary schools were open from the same date, but with testing. And again, the testing is 3 times a week. The children take a lateral flow test, and if that comes back as positive, they go home with the PCR test, and the test is done at home. We are recommending that face coverings are available in secondary schools. Again, that's not mandatory, but I think most of our schools have put that policy in place wherever possible. There's quite a lot of discussions about catch-up in terms of children's progress, and there's some discussion about extra lessons in the holidays. We in Reading are looking at what this will mean for children with our head teachers and working very closely with our head teachers to make sure that the children get the best that we can give, and the schools can manage that as well. So there's still lots of discussion going on around how that will happen and how it will work. The government are very keen on the national tuition programme, and our schools are currently evaluating that and having a look at how that will work. Next slide, please, Nikki. That's the end of my slides. I don't know if anybody's got any questions for me.
Thank you. Should we, as with David, should we take the questions at the end? We go through them all. Yes. People may also have, then they may connect as well. So, and hopefully that's okay. In which case, thank you very much for that. That was really important, interesting statistics there. Right, from Berkshire West in ICP, impact on primary care and acute hospital services. Who's going to be introducing this?
I think you've got me, Chair.
Okay,
do this item.
Excellent.
So hello everybody, I'm Dr. Andy Tchersky. I'm a GP at Emma Green Surgery. I'm a clinical director of the Caversham PCN and also a clinical lead still at the CCG, and obviously the vice chair of this board. So COVID-19, the impact on primary care services. So throughout the pandemic, GP services have changed to a remote triage and remote consultation model. That was the guidance we were given by NHS England. Obviously, at the start of the pandemic, we just didn't know what we were dealing with. So we tried to keep not only ourselves safe, both in primary care staff, but also keeping patients safe as we were in the lockdown situation. As we've gone in and out of lockdowns, we haven't changed the way we're working, and we won't be changing the way of working anytime soon because we don't know what's ahead of us. Obviously, we're all very optimistic with the results of the vaccination program. So just so everybody knows, though, many of you, I'm sure, have had contact with your own surgeries, but practice now triage patients remotely with a telephone, through a telephone call. Some patients asked to do it through online, through either an email message, and then we respond back with a telephone call with a consultation on the telephone. Sometimes we use text messages to share information that way. Some patients like to do video consultations, and some practices are a little bit more up with doing video consultations than others. And then deciding if we actually need to see the patient face-to-face, depending on the problem. So to see patients in the surgeries, we have hot and cold streaming arrangements. So cold patients are those who are well. They're coming in for routine tests. They see our nurses for their blood tests, for dressings, for routine checks like antenatal checks, baby checks and immunizations, cervical smears. There was a little bit of a lull right at the beginning of the pandemic, but we're literally within 2 or 3 months, we had to get back to doing those things. The guidance was advised to try and get back to doing it. And certainly across the Reading practices, we were doing all those routine things. So some things were stopped that we didn't do routinely, things like minor surgery, which was put on hold, and a few other routine things, but all the important services were maintained. So at least 50% of the consultations are still face-to-face in a surgery, but it is less than it was before because the vast majority of the doctor consultations start with a telephone consultation, and there's a small proportion of those, maybe 5-10%, maybe slightly more depending on, in any particular time, would then turn into a face-to-face consultation. So we have to keep the arrangements going as we are. It's important for the safety of our patients and for our staff. It has actually improved capacity to manage on-the-day demand. Some patients have been reticent to come forward, and then the problem becomes a bit more of an urgent problem, so we have to deal with it on the day. There's less sort of routine work that needs to be booked up in advance. So we deal with things as they crop up. And in fact, when you look at the numbers of consultations in primary care, there's some data there from the period between October and December last year. The actual average monthly consultation rate was more than it had been in the previous year. So primary care is actually working harder and actually having more consultations than it did the year previous to the pandemic. The Reading Walk-in Centre, we had a walk-in service. The name is a bit of a misnomer, really, in current times. The walk-in element of the service there was suspended through the early part of the pandemic. About October time, as we all came out of the sort of lockdown period and when thinking about the move into winter, it was restarted, but like all primary care services, it was only initially for telephone consultations, and it had to be bookable appointments through 111. So patients would ring 111, they'd need to be seen by somebody or speak to somebody in primary care, and they would be booked into that service. So that would be majority of those patients would be patients who weren't registered potentially in Reading or couldn't get hold of an appointment with their own GP. But the numbers were very low, and that's because primary care and their own GPs were so available that patients would be able to get an appointment with their own GP. So the use of the walk-in centre was underutilised. Going forward, please. So the impact on primary care services. The next bit is about the respiratory hub that was established in the walk-in clinic throughout the pandemic. So when the walk-in service was stopped, the respiratory hub was started, and this was to allow for COVID-19 patients with COVID-19 symptoms to be assessed. Now, at the time, we just didn't know what we were dealing with. There was a lot of panic about having those sort of patients coming into GP surgeries. So we focused the expertise, that we focused the equipment and everything that was needed at the time at the respiratory hub. Clinicians were trained in sort of very strict PPE. Patients felt safe being seen there. Clinicians were felt safe, and I think, as far as I know, the data is that no clinician working the respiratory hub caught COVID from their work in the respiratory hub. They had a capacity initially to work at sort of 100 patients per day. And they had to flex up and down. I don't think they ever hit 100 patients per day, even during the worst days of the pandemic. But that was how much it was geared up to be able to see that many patients. And the number of teams that were on duty any time was flexed to be responsive enough to be able to deal with the number of patients potentially being referred in. So GPs would talk to somebody on the phone, potentially had COVID symptoms. So rather than bring them into the surgery, they'd be referred to the respiratory hub and they would be assessed there. If there was a need to refer them on, they would be, but in fact, because they could be managed so well by the expertise of the service, it reduced the burden of patients having to go to A&E, and they could be monitored remotely. So if we move on to the next slide, it will tell us a little bit about, I think the next slide is about the oximetry at home service. So the respiratory hub was doing this all the way through from right at the beginning of the pandemic. That was one of the ways to manage patients, is to give them a pulse oximeter to measure their oxygen saturations, and they would monitor these patients remotely. They then worked with the hospital on something called the TIC-19 pathway, where patients in the hospital were seen and then discharged to be monitored. And then the two came together and it worked as one seamless pathway. So all the patients were managed in a consistent way. Primary care would then, as we went through, not all the areas had a respiratory hub. We were very fortunate in Reading. And so some practices across the country then developed this oximetry at home service. Then the national team, NHS England, advised that all practices should be looking at doing this. And some practices in the Reading, West Berkshire area did do this with their patients. Rather than sending them to the hub, they felt confident enough they could do this themselves. So the patients would monitor their oxygen levels at home. There would be some criteria for when they would need to contact the GP. If they dropped below a certain level, they'd normally be monitored for sort of 7 to 10 days after they had got COVID. And then if they had deteriorated, they'd be referred up to the hospital because of their positive COVID test and their oxygen saturation is dropping, and then the hospital would step in and deal with their care. Now that we're coming out of the pandemic, hopefully we won't need to do this for very many patients. That's the hope. So if we move on to the next slide. So just a little bit about the vaccinations in primary care, and I'm heavily involved in that because I run the Emma Green local vaccination service in Caversham. So I think, as David alluded to, the numbers that have been done in Reading, the vast majority of the initial uptake was done by local vaccination centres, and there are 5 sites across Reading. I think we've got 11 across Berkshire West. And certainly from the middle of December, when the first sites went live, they started vaccinating the cohorts 1 to 4, the over 80s, then the over 75s, and then the over 70s, and also the health and social care workers and the extremely clinical vulnerable patients. And certainly amongst that cohort 1 to 4, I think pretty much across all vaccination sites, the uptake was over 90%. We've been working very hard to then get cohort 6, the under 65s with clinical conditions in. It's been really a huge task because we have the records for those patients, so we know those patients best. It wasn't really possible for the mass vaccination sites or the national booking system to call those patients in. It's all the way down to the over 18s. So we had to stratify, you know, the clinical conditions, get them in an order, because it was a whole mixture of patients with diabetes, respiratory conditions, obesity, mental health problems, learning disability problems, urological problems, the whole gamut of clinical conditions that fit into that. So it's actually a huge number of patients and a huge effort to get those patients in. I think we're pretty much done with cohort 6. We've pretty much got them all in. In our centre, it's just 1 or 2, you know, the last few patients that we needed to get done. The mass vaccination sites came on online doing the over 65s and then going down below that age group, and certainly we've been then starting to invite those patients in as well. So I think we're quite well on track to, by the middle of April, by the 15th of April, I think, which is the national target, to have got everybody down to cohort 9 vaccinated. In fact, it's a little bit of a competition now for the mass vaccination sites have done so well with getting those younger, older age groups, if you see what I mean, in, that we're actually having to work very hard in the local vaccination centres to get those patients in, and we're really mopping up those that haven't taken up the offer from the national offer, and trying to say, look, come to the local surgery, come to the local sites and get your COVID vaccination. So we're really trying to penetrate those patients who haven't sort of been, you know, chomping at the bit to go to the mass vaccination centres. And that's been really where the working group with focusing on inequalities, especially in central Reading, where we've got such diversity, our ethnic diversity, trying to get those patients in. The central Reading team has done a fantastic job at Watlington House Centre, and it's still a bit of ongoing work over the next few weeks. So if we move on to the last slide, I think that's the last slide, yeah. So recovery plans, well, it's not really a recovery from a primary care point of view, because it's ongoing work. I suppose there will be an element of recovery. One of the things we'll continue to have to adapt to is certain changes. So the Respiratory Hub will end at the end of March. Basically, the numbers don't justify it still running, and the number of patients that will still come through with COVID symptoms will be managed in their patients' own practices. The team will still be available to give advice, but I think everybody's been doing this for long enough now that I think that GPs would have confidence to be able to do that. And surgeries will still have a hot room where patients would be seen for examining patients, whether they've got COVID or not COVID, and we've got all the PPE and all the cleaning arrangements in place. So the odd COVID patient coming in will not be too much of a problem. This has been an opportunity just to share with you how primary care is working, and obviously we've still got a lot of work to do with patients who've been shielding, letting them know that how primary care is working, that we are working as a triage first, telephone first, or online first service. So there's electronic ways of getting in touch with us as well as on the phone, and that we can respond to a vast majority of patients' medical queries using those modes of communication. The next phase of the vaccination program, it will be a challenge for everybody to deal with the next groups 10 to 12 that David mentioned earlier on. We're waiting for the national go-ahead. It has been delayed, and that's going to be frustrating for those groups because of the vaccine supply issues, but hopefully by the end of April, beginning of May, or whenever the vaccine comes available, the local vaccination sites will be those hoping to support that program. I think primarily less vaccination sites will be catching most of the younger population, but there will be some local vaccination sites also available for those patients to go to. As far as backlog of routine appointments, I think most of that's probably already been done, because we've very much tried to get back to some sort of normality of seeing patients or dealing with patients' problems in terms of the routine things a few months into the pandemic. They're sort of around May, June time. And so really since then, we have been dealing with the backlog of the routine appointments, chronic diseases. We're doing it differently. We're doing it through telephone follow-ups and doing things without having to bring patients in. If we don't need to, nurses are doing asthma reviews, for example, on the phone, using questionnaires, which are quite sensitive and such like. But we are seeing those patients that do need to come in for regular monitoring, blood tests and any specific tests. So we're looking to try and improve our vaccination and immunization screening rates. I think we've done quite well from the sort of lull of the early pandemic, and people are up to speed again. And there's still a lot of work going on currently to focus work on learning disability health checks for those patients that would have been shielding for a vast majority of the time during the pandemic. Physical health checks on patients with severe mental illness. We know these are the two of the groups that we know well as our patients who would have suffered through the pandemic, whether through learning disability patients not being able to get out and not really understanding what's going on, and those patients with severe mental illness struggling with being in lockdown. So we've been tasked in primary care to look at those patients specifically, and by the end of March, all practices should have had done a review with a majority of those patients and making sure that they're okay as we go forward into the next few months, and then hopefully out of lockdown. So that's the update from primary care. Thank you.
Thank you, Andy. So we've just got the Royal Berkshire Foundation Trust.
Yeah, great.
Yeah. And then we'll take sort of questions and points at the end of that. Thank you.
Thanks very much, Councillor Hoskins. My name is Dom Hardy. I'm the Chief Operating Officer here at the Royal Berkshire NHS Foundation Trust. I've just got a few slides that I wanted to share with the board today to give an indication of what's been happening here, what we've learned from that, and where we are now and what's ahead of us. The first of three slides that I've got shows the trend in cases that we saw in the two waves. So although this is small in terms of font, the greenish line shows the number of cases we saw, that's in patients who were COVID positive in the first wave. So you can see the spike there in early April in 2020, declining during May, and then over the summer months almost to zero by September. But then you can equally see plotted against that in the purplish colour the tremendous increase in COVID positive inpatients we saw over January and indeed in February. So that substantially surpassed the peak that we saw in the first wave. And the reason I present it like this is to show not only did we do a good job on behalf of patients in the first wave, we learnt an awful lot about how not only to treat COVID positive patients, but also to sustain as many other services as we possibly could during the second wave of the pandemic. And that's learning that's still going on today. If I could have the next slide, please, Nikki. So just to be specific then about the impact of the second wave of COVID on our organisation, we did have caused to escalate at a significantly greater scale compared even with wave 1. And at the peak period, February and into this month, we had almost 3 times the capacity that we would normally have in our intensive care unit. So that was over 40 patients, and we're funded for 15 beds. And you can imagine that those are the sickest sickest patients requiring most care, and therefore that requires a real intensity of effort. That was offset slightly though by our attendances at our emergency department being substantially lower than usual seasonal levels over the Christmas and New Year period. In part that was because people with kind of minor illness tended to stay away, perhaps using general practice or other forms of care. But it was also because we saw almost no seasonal flu circulating this year. And that helped enormously in terms of constraining demand on our services. On this occasion, for the second wave, we sustained all of our urgent and emergency surgery, as well as almost all of our diagnostic services. So that's meant that we've treated patients when they've had kind of urgent need, but we've been able to sustain more routine services like, for example, endoscopy services. We've also, and this is to Andy's point as well, maintained a number of our outpatient clinics by using all of our sites, and particularly by increasing the number of phone and indeed virtual consultations that we've held. We've continued to take general practice referrals throughout the second wave, so there's been no hiatus, as there wasn't in the first wave, in patients being referred to us and then triaged for treatment. And I just wanted to acknowledge the work that we've done with local authority and Berkshire Healthcare partners in particular to ensure safe and timely discharge of patients. The collaborative working that's happened there has been really tremendous and has helped us enormously. So I do want to extend our continued thanks to colleagues there. We've also benefited from a really significant amount of continued support from our community, whether that's local businesses, schools, the University of Reading. That has been invaluable actually to us over the course of the second wave, as it was in the first wave. Next slide, please, Nikki. And then my final slide, just to summarise where we are today. We're seeing very, very few COVID positive patients each day now, perhaps 1 or 2 admissions. Yesterday there were none. And we've really reduced the capacity in the Royal Berkshire Hospital that is dedicated to caring for COVID patients. It's largely concentrated on a single ward, and it doesn't occupy the whole of that ward. We continue to sustain our efforts on infection prevention and control, and we're obviously putting a great deal of effort into supporting our staff and their well-being, particularly those who've had cause to be most involved in responding to the pandemic. We've had a very successful first phase of staff vaccination, and we hope that will not only reassure our staff but also reassure patients who are likely to come here that will really reduce the risk of transmission to them. And our phase 2 vaccination programme for the second round begins early next week. We are currently focusing on ensuring every single one of our services is back up and running efficiently, and particularly on making sure we can run all of our routine diagnostic and surgery work across all of our sites. And just to scale that for colleagues, this week last week, we were running at around 85% of our inpatient and day case surgical work compared with 2019-20. And while that sounds like we're some way off our normal capacity, that's a really tremendous effort to get back even to that status so quickly after the peak of the pandemic. And we're really ambitious in terms of getting back not only to 100% of what we were doing this time 2 years ago, but actually pushing beyond that, recognising that there are many, many patients in our community who've now waited a very long time for their treatment, and our commitment to them is to make sure that we can accommodate them as quickly as possible. We're also finally in an ongoing phase of making sure we learn every single lesson we can from both of the waves, actually. We hope we can avoid a further serious wave. The modelling suggests that we're likely to have a kind of smaller peak, I think, in the early to mid-summer. David may be able to say a bit more about that, but we hope that given everything that we've been able to put together, all of our learning, the impact of the vaccination campaign, we'd hope to avoid any significant disruption should that peak occur. So that's the picture from the Royal Berkshire Hospital from the COVID perspective. As others are, very happy to take any questions.
Great, thank you very much for that. Any questions? If anyone wants to ask a question, make a point, if you indicate in the chat. I've got a few people raise their hands, so it's difficult to keep up with that, but I have seen that Mandeep Baines from the Health Watch has indicated. Mandeep.
Thank you, Chair, and thank you for all those presentations. Amazing work across all services and so informative. Thank you. Just to be fair, I've got a question each. I wonder, Andy, if you could say a little bit more about the capacity of GP services at the moment with coping with doing vaccinations, as well as supporting people to access day-to-day services and their routine appointments, as well as on the day. And a question for Dom, really. Dom, could you give us a bit of an idea of the timeline you're working towards in terms of services returning to normal? Because one of the things we learned throughout the pandemic is communication is so important, and so much of what we've heard across all the presentations today is really important for patients and the public to know about how services are coming back to normal and what is happening where. So a little bit more detail, I think, would be really helpful if you can give it at this time. And just one last question for David. David, we've just been hearing that Reading has done slightly fewer vaccinations than some of our partners. Could you say a little bit more about that? Thank you.
Shall I go first, chaps, as I had the first question? I can't
Andy.
remember what the question was now, but I think I remember the question. Okay, so I think, yes, it has been a bit of a challenge with vaccinations to keep normal services going, but that really happened right at the beginning when we did the first vaccinations, when we had the first Pfizer vaccine. You know, it was all hands to the pump really to provide the service. Certainly, just as an example, here in Caversham, we had 3 batches of over 1,000 vaccines to give in 10 days. So we were working pretty much flat out for 10 days, every day vaccinating all day. And that meant we needed staff from 2 surgeries working to get all those patients through. And Pfizer is difficult because of the waiting time. So it was labor intensive. So we had a bit of disruption then. That was for us, that was in the middle of January. And then once the Pfizer was done, basically it was back to normal working. So we had maybe just a few days where patients couldn't get in for routine things. There was still urgence on the day being done. Probably I can sort of, my practice manager won't mind me saying, we're going to have a similar picture when we get our second dose vaccine of Pfizer. It won't matter to patients too much because actually the first doses will be vaccinating on Good Friday and Saturday of Easter. So we wouldn't be open anyway, but we'll be here vaccinating. The following week, we will again have 2,000 vaccines to give in a space. Currently, we understand 3 days, but it might be lucky that it will be stretched over 5 days. So if we have it over 3 days, we'll be working 12-hour days for 3 days, just vaccinating. So there will be some disruption to routine services for 3 days. There will still be urgent care available on the day. And our host, our colleague practice will be supporting us with seeing patients off-site because our site's going to be busy doing that. And that's just one example of a solution. And I think across other practices, they'll have the same sort of sudden flurries of vaccinating, which will obviously have some effect on patients' access into a surgery, unless the vaccination is actually done off-site in a separate centre I know there are a number of vaccine centres which aren't in the practices. We are in our surgery. So they will still have teams working in the background, still on the phone, still dealing with patients, still arranging all the urgent on the daycare, and to some degree managing to keep routine care going as well. And I know those practices which arrange an off-site vaccination centre, like in a hall or a centre, that's allowed them to keep normal services going in their surgery. So general practice is still open, it's still going. Yes, in a few areas for a few days there might be a slight impact because of we will be sending out messages. We are vaccinating flat out for the next 5 days. Please just give us a break. Just come be in touch for the urgent things. But all the routine stuff will be picked up the following week.
Thanks, Andy. Mandy, that was a great question you asked about how quickly services will get back to normal. I mean, the short answer is as soon as possible in every single case. I mean, partly that's a lot easier this time because we didn't stop doing very much. The main activity that stopped was routine surgery. So that might have been cataract surgery, for example. But even then, we managed to sustain a level of service on our Prince Charles Eye unit site out at Windsor. So what I'm talking about here really are services on the Royal Berkshire Hospital site. To be more exact, we want to be back to the kind of activity levels that we were doing in April 2019 from next month as quickly as we can. And I think there's every prospect that we'll be in that position. What we need to do, though, is actually go further than that. We need to be more productive than we have been in the past and actually do more activity so that we make sure we are able to care for patients who are newly referred by their GP or have been waiting for some time. So that's one of our key challenges for teams around the hospital at the moment. Two caveats. One is about the ongoing constraints that the pandemic and the infection prevention and control measures impose on us. So that means we have to retain social distancing, at least for the time being, throughout the hospital. And so you can imagine that in a clinic area, we can't, or a waiting area, we simply can't have as many people waiting as we might normally want to have. We'd hope that those restrictions might get relaxed over the next 3 or 4 months, but we can't be sure about it. But that does constrain us a little bit, and it means asking patients, for example, not to turn up early, but to turn up almost bang on time, just so that we can ease the flow for them. And then the second thing is, although we'd hope that most of this wouldn't be obvious to patients, we're not automatically going back to how we did things before the 2 waves of the pandemic. We've learned so much, actually, that we want to take the opportunity to build on some of those changed practices and do things better, frankly. So we know a lot of our patients have really enjoyed having telephone or sometimes video consultations because they haven't had to leave work for an appointment, come and try and park on the Royal Berkshire site, which is always tricky, and lose important time out of their day. Sometimes it's been much more convenient for people to be able to access that kind of consultant input via a telephone appointment. But it is about matching the way we do things to what patients want. And so I think the work we're going to continue to do is to really mine your expertise to make sure that as we kind of make sure everything gets back as close to normal as possible, we are continuing to get the feedback that you and your colleagues are able to give us, Mandy, because it's really appreciated. Does that help answer the question?
And so if I come in then on the vaccination kind of numbers answer, so there's a few bits to it. I'll be very brief. But in terms of the numbers of people vaccinated in Reading, our population in Reading is predominantly younger than average than older than average. And what that means is to achieve a good uptake level of the vaccination with where the programme is at currently. So that's, for argument's sake, say those aged 60 and over, you need to vaccinate fewer people to get 85, 90, 95% uptake for Reading than you would need to in Wokingham, in West Berkshire, in other areas, because there's just fewer of those people, relatively speaking, compared to other areas. So that's certainly one of the reasons. Another is that where coverage data has been presented, so the percentage of the population that are vaccinated, the denominator that's used, so the total number of people in Reading on the National Information Management System, where the numbers are crunched, isn't particularly accurate for Reading, and it's probably an over-representation compared to the number of people that actually live in. I know that might sound like an odd thing, but when you compare the number used to the number that the Office for National Statistics give for the number of people living in the borough of Reading, it is inflated, and more so than in other areas. So I think those are two of the reasons. And then I think thirdly, our diverse community in Reading, which is part of what makes Reading the vibrant, the place that it is, the place that we all love, means that there is more work we need to do, because some people will be a bit slower in coming forward for vaccination. And that's the work that's ongoing, as I kind of referred to, and I know that you're engaged with, to try and ensure that we cover everyone in Reading. And I think in some other parts of the county and beyond, that's probably a little bit simpler, but we're very much kind of doing the work and wanting to make sure we bring all the communities with us.
Oh, great. Sorry, I was struggling with my mute button. Thank you very much for those answers. Right, I've got Ramona Bridgman indicating. Ramona.
Yes, thank you, Chair. So I want to just highlight, following on from the education report. I mean, it's really good to see how much work has been done to get so many children back at school. Sorry, my daughter's singing in the background. I beg apologise. I'm from Reading Families Forum, so we represent disabled children 0 to 25, and I just want to highlight that not all children are back. Clinically extremely vulnerable children aren't due back until the 1st of April, so that'd be after half term now, after the Easter holidays. And there are a number of children, I think there is about 6 in my daughter's 6th form, who haven't been in school for over a year. And it's taking a huge toll. I think I've spoken with some of the special schools, and the impact on the learning for children with severe and profound multiple learning disabilities isn't as great. They seem to respond to home learning fairly well, but the socialisation and isolation is huge, and the pressures on parent carers who haven't had a break for a year is immense. And we're hearing from parent carers saying that they are breaking point and they're absolutely exhausted. And it also has a huge impact on siblings of young people who are clinically extremely vulnerable, who are having to go back into school. We had one lad who had close contact with another child who had COVID in his class, and he was terrified returning home. He was wanting to sleep in the garden in a tent because his brother is extremely medically vulnerable. And it's just to highlight the huge amount of stress that families are under as a result of that. I don't know whether it's in the gift of public health or the CCG to ensure that those children and young people get their second vaccine and get moving with it, or because they have been out of school for over a year now. And I just wanted to highlight that for the group and see what could be done. And also when we're talking about, catch up in the holidays, that there are parents who are absolutely exhausted, and safe respite would be really valuable to be considered within that mix, please.
Right, thank you, Ramona. A really important perspective. I don't know if there's anybody that can come back on Ramona's question around how the vaccination of young clinically vulnerable. Is that something anyone can answer now, or something we need to? Andy, brilliant. You're raising your hand. Thank you very much.
Okay. I know that in our practice, because we've got Pfizer coming back to do second vaccinations imminently, the under 18s, the Pfizer vaccine is the only one that's licensed for use in the 16 to 18-year-olds. And then for anyone under that that's severely clinically vulnerable with a clinical condition, again, it's advised that we give it Pfizer with the recommendation of a consultant specialist. because it's off license. So we can't use Astra in anyone under 18 except in extremely exceptional circumstances. That's the advice we've got. So I know we've got a list of patients who are under 18 who will be able to vaccinate when we get our next vaccine supply in.
Right.
And I think that I'll follow on that just to answer the question also, Chair, that come up on the chat about balancing new first vaccinations with those at 12 weeks ready for second vaccinations. Well, the vaccine supply we have been assured is secure for our second vaccinations to reflect those that we gave the first time round. Hence the modelling I just mentioned earlier on of us having to start doing our Pfizer vaccinations over the Easter weekend. And then we will have a mirror supply of those that we did the first time round, so we can then give those same vaccinations to patients for the second vaccine. The challenge, yes, will be how do we do first vaccinations at the same time? They won't be done literally at the same time. We will have to do the clinics that we did before for first vaccinations, repeat them second time round, so patients get their second vaccine at the correct time. And then we'll be doing extra clinics around those for first time vaccinations. And that would be when we are allowed, it will be for those cohorts 10 to 12. As like I said, we've probably finished cohorts 1 to 9, and quite fortuitously, we've done that just in the nick of time prior to going back into doing second vaccinations. So actually, there won't be much of an issue of mixing first and second doses. So it will be second doses primarily, and then fitting in first doses for cohorts 10 to 12 around them. I hope that answers the question.
Thank you. Thanks for that, and thank you, Ramona. And perhaps we'll catch up in terms of we can make representations around, because I think the priority or the balance of when those younger clinically vulnerable are going to be looked at is something perhaps we can raise and see within the NHS programme how that is. So thank you very much for that. I've got Jill Dunlop as indicating.
Thank you, Councillor Hoskins. Oops, camera back on. Ramona, hello. Just to reassure you that we are trying to work with our SEND department and special schools in terms of how we get these vulnerable children back into school safely. I also acknowledge your point about some children that have been away from school for quite a long time, and there are some children that have found home learning and remote learning far less stressful than being in a busy school environment. So we take your points on all those, but we are obviously trying to work with families that may be more anxious, or their children might be more anxious about getting into schools, or they've just found the routine at home much more easy to manage for themselves. We're working with education welfare, with the special educational needs team to look at how we can get those children back into school safely and confidently, because we are aware of the issues that you've raised, and thank you for those.
All right, thank you, Jill.
Okay, thank you very much for those questions and those answers, and for the presentations. I don't see anybody else indicating, in which case I've already said thank you, so I won't say it again. We'll move on to the next agenda item. I'm going to propose, although we've still got quite a long time till 4 o'clock, I'm going to propose taking 7 and 8, and that is because Catherine McDermott, who's going to be presenting on both of those from Berkshire Healthcare Trust, has to be away by 4 o'clock. So rather than risk going over when she needs to be away, I'm going to propose 6 and then 8. So next item is Catherine, and you're here on the BHFT update on recovery from COVID-19. Over to you.
Thank you so much, and thank you for so much accommodating the agenda shift. I can't see the slides. Is it just me? No, it's as we speak. Thank you so much, Nikki. If we can it's interesting actually listening to Andy and Dom from GP and Royal Berks. It's actually quite a similar sort of story, but I'll take you through. If we can go on to the next one. What this slide basically does is just give you a sense of the programme aims. So we established a recovery programme whilst we were actually still in wave 1, because we knew we'd need to establish certain criteria and principles that would help us make this, and if we had to make really difficult decisions. We did have to make some difficult decisions, as other people have had to do, about how do we change our service offer, what do we need to keep going, and how do we keep going, and how do we redeploy staff. So there were quite a few things we had to make difficult decisions on very rapidly. And the benefit, if that's the right word, one of the easier things in the second wave was we'd already made some of those difficult decisions and set some of those principles in place during the first wave. And basically the principle of recovery and restoration is to try and get the services back to the points that they were pre-COVID. But you'll see as I go through, we won't be going back to exactly the same service offer that we had before COVID. It's just not going to be possible to do, but I'll talk you through that as we go through. If we could move on. What I've done in the presentation for you is I've divided up the service offer we provided during wave 1 and wave 2, and hopefully you'll see from that we have been able to continue more services during the second wave than we were able to in the first wave. For adult community health services, we had to cease all non-urgent community services, so that's everything except urgent was moved over to a remote offer. So that's either telephone, one consultation, Teams. There were various ways that we provided those. All urgent and crisis services continue to provide a face-to-face, but everything else was moved over onto a remote offer, and that was completely in line with the national guidance. I've given you some of the examples of the services that were moved. I don't need to talk you through every single one of those. But in wave 2, a lot of the services that we'd had to pause during wave 1, we were able to continue the service offer, and that's because we had established what we're calling a blended model. So a lot of our services will now offer triage, for example, remotely. So the community nurse might phone up. There might be photographs that are whizzed over to the community nursing team. Follow up, a tissue viability service, for example, will have patients take photographs of their wounds first, and so they can schedule in the visit at the right time, so it minimises distress to patients and unnecessary face-to-face contacts. So community health, we have continued to visit all urgent and crisis, and that does include home visits to people who are very vulnerable, but we have moved a lot of services onto remote and online. It's also impacted on clinics that we provide out of a range of our premises, and it's also impacted on the number of appointments that we can deliver in our premises. And this is primarily to do with, and I think Dom referenced it earlier, the fact that we have to be so careful now about the numbers of people in our buildings at any one point in time, being really strict about scheduling appointments, minimising potential contact points. We've had to redesign the flow, so the way people move in and out of our buildings, and I'm sure you're all used to it now, you've been in plenty of places. So all of that has had an impact on our service, and we see that having an impact for at least the immediate future. So I'll be sort of frank about that. If we could move on to the next one. What I've done here, hopefully it's clear enough for you to see, is give you an idea about how the referrals change. So it's a bar graph, whereas Dom did you a lovely chart which showed you the flow, the rise of the peak. What this is demonstrating is the impact that it had on our referrals pre and post COVID. So you can see a similar sort of pattern where the referrals really dipped during those the period of the waves, and you can see how they're moving up again, and they've started to dip again as we went into the second wave. and I've given you East and West just as a comparison. No, that's fine, thank you. In terms of children and young people, we did suspend some of the elements within children's services in the first wave. We were required to do so, and we were able to move our immunisation teams, school immunisation teams, over to frontline. So a lot of them were redeployed into our community wards, which were taking a significant number of COVID positive patients at the time. We had to suspend all face-to-face appointments unless there was a really urgent need, and we were able to maximise the use of a range of different digital offers, both for CAMS, IAP services, a lot of which we will continue to provide going forward. In terms of wave 2, apart from the vaccination team, which has now not been redeployed to the wards, but has been redeployed to Workingham Hub to provide the COVID vaccinations, a lot of the other services remained largely unchanged. But again, a lot of those new ways of working are continuing to go forward. We had redeployed our school IMS nurses to the Workingham Hub to provide the vaccinations up till the end of Feb, and we backfilled those vacant posts with bank and agency staff to continue to be able to provide those services. If we can pop on to the next one, please. This gives you a similar sort of picture of the referrals that were made to children's services pre and post COVID, and you can see the same sort of pattern flowing through there. If we pop on to the next one. Thank you. In terms of adult mental health services, the majority of the services actually continued business as usual, but for some, such as older people's mental health, it did include a move to telephone appointments where it was deemed appropriate and face-to-face. So something like adults mental health, the dementia clinics and memory clinics, because they were group-based clinics, they all had to move on to remote and digital-based appointments, which has, to be honest, has been a mix. Some people have responded really well to that and some people haven't, and we are aware of that, and when it's safe to do so, we will be recommencing the face-to-face appointments in those areas. In terms of our inpatient wards, there were no change apart from the massive pressure that the wards in Prospect Park came under. We redeployed corporate staff from corporate services into Prospect Park, and they helped with a lot of things like liaising with patients and their families to enable the clinical staff to really focus just on the clinical work. If we move on to the next one. Thank you. Similar sort of graph, the referrals made into adult mental health pre and post COVID, and you can see the same sort of pattern that you've seen on the earlier slides. If we move on. Just to let you know, during the first wave, national guidance was that the reporting on serious incidences was suspended, but we actually continued to compile any complaints and any serious incidents on our own system. So we did keep those, we did keep an internal record of those, and we have continued to use our own internal processes to do the review and learning from any of those. And it's helpful, I think, to share that in the second wave, that reporting has continued and the duty of candour has continued, and we've continued to provide that throughout. And then the next one, please. It is worth mentioning the impact that this has had on staff. And we did redeploy in the first wave significant numbers of staff across different services, and we did have to shore up wards. So I've already mentioned that we use the school nursing IMS team and other children's services nurses to help support the wards, the community bed wards. We did redeploy corporate staff into Prospect Park to help free up clinical staff there. We used the physios from our MSK service to help with the hospital discharge service that Dot mentioned earlier, which is still the case. So there were a lot of movements of staff, and our staff have been absolutely brilliant at really working really hard and really sort of answering the call for help. It does mean that they're exhausted. We've been doing this for quite a long time, so I just wanted to sort of log that, you know, the huge thanks to all of our staff that have been working through this. We have started to think about what recovery means for our staff as well as for our services. So what the risk at the moment is, people are going to be so exhausted. If we have another wave, they're just going to think, I'm just too tired, I can't do this. We really don't want to start losing staff. So we are working really hard on our staff wellbeing offer, and being very explicit about that. We can move on. And finally, what I wanted to mention was the reducing health inequalities. What we refer to as the phase 3 recovery letter included a duty on all NHS providers to have in place what's called a reducing health inequalities due to the impacts of COVID action plan. And we've established our own action plan. I call it the 8-point action plan because there are 8 points within it that you're required to deliver on, and it includes things like, reducing the risk to vulnerable people, making sure there's equity of access to services. So we have a plan in place, and we report against that to our recovery programme board. We have, because of that conversation, also now established a separate reducing health inequality strategy and established a reducing health inequality steering group that has oversight of all of those. So some positive has come out of this. So that's, I think, it's probably where I want to end. I think the next slide says thank you very much, and if there are any questions.
Thank you very much. Yes, any questions? Any points anyone wants to raise? I haven't got anybody indicating at the moment. Obviously did an extremely good job. Oh, we have got Shona Douglas.
Yeah, thanks ever so much, Councillor Hoskin. Thanks, Catherine. And I know that our teams have been working closely with you, as we have with the RBH, around the challenges that we've all faced, and I guess that it's just the bits around acknowledging, isn't it, that because some of the services haven't been provided for in the same way, and that's for all of us over the last year, that what I know we're picking up in social care is people who've got, well, Ramona's also referred to it as well today, is really kind of exhausted, high dependence, and we don't know at this stage, people who haven't had therapy input and those things, what the level of deterioration is when we all get back in there. And I think it's just to acknowledge that all of us are in this together, and it is going to be about how we work cooperatively, isn't it, as a system, to ensure that these people get the right support, because I think some of us are a bit concerned. We're not sure what we're going to see as lockdown evolves and what the issues are. So I suppose I was just kind of flagging that, because I know that I know we've had conversations about some of the therapy inputs from social care, that people haven't had the physio that they would have needed, which would have perhaps optimised their independence a bit more quickly than it has done. And I suppose it's just acknowledging that as a system, is that we're going to have to work, aren't we, quite closely in terms of supporting each other and the families and individuals in the borough who are going to experience some difficulties.
Thank you. Oh, sorry. Thank you, Shona. I don't know if Catherine had anything to respond to that.
I think it's a point really well made, and we were only just beginning to see the impact in terms of what we call the acuity and the level of referrals into mental health, the frailty, that there are so many people for so many different reasons who aren't making those contact points, and Shona quite rightly points out, are deteriorating. So when we pick them up, they are a lot more poorly and a lot more frail than they would have been. And you're absolutely totally right. The only way we're going to make a difference is if we really pull together on this.
Okay, great. Anyone else? I haven't seen anyone else indicating, in which case, Catherine, thank you very much for that. We'll move on to item 8. However, I do need to leave in 9 minutes. So what I'm going to propose, I'm going to seamlessly hand over the baton to my vice chair, Dr. Andy Cichersky. Hopefully will indicate that he's now taking full control of this meeting. Andy. Yes, excellent. He'll do an excellent job for us. Obviously, we're going back to item 7 once we've done item 8. So,
okay, I shall take over. So item 8, Catherine, would you like to continue as you're in full flow?
Thank you very much. If we
on your next item.
Pop onto the next slide, that'd be really helpful. Thank you. I'm going to cover off, I'm going to give a bit of background on the NHS long-term plan. Clearly, you've asked me to give an update on the mental health, on Berkshire's mental health strategy, so I will do that. But what I want to say also is that the strategy we're looking at should have ended in 20, but a lot of the work we were planning to finish off, we've had to roll over into next year for very obvious reasons, and I'll flag that when we get to that. I was also planning to give you a bit of an idea of the impact that COVID-19 has had on mental health, and I think that's an early warning. I don't think we're out of the woods yet, and depending on if we have further waves, depending on unemployment, depending on the impact on the economy, we could see a very complex mental health environment going forward. And then I thought it would be helpful to share the priorities for 21-22 going forward to give you an idea of the sort of things that we're focusing on. So hopefully that sounds of interest, and I'll pop on to the next one. Hopefully I'm only looking at a laptop, so hopefully you've all got bigger screens and you can actually see this quite clearly. The NHS long-term plan really did emphasise that mental health was still one of those top priorities, and never more so now because of, you know, having lived and living through a pandemic, really emphasised the importance of community mental health, about getting that integrated into primary care networks, looking at alternative provision for those in crisis. We now have proposed reforms to the Mental Health Act, which talks about much more therapeutic interventions rather than, you know, going straight to the very heavy medicated ends. Looked at improving the capacity and access to psychological therapies, making sure that we really emphasise the physical health of people with serious mental illnesses, and Berkshire has just agreed that is one of our, we call them a breakthrough objective, but basically it means that that's one of our top priorities for 21-22. So every team will be required to demonstrate how they contribute that. Emphasis on children, young people working in schools and colleges, emphasis on learning disabilities and autism, of course, of which we are a provider of, and then some enablers around accessing the services through 111 and providing 24/7 community care. So the next one, please. And then these are some of the specifics that they included in the long-term plan. If we move on. I thought what it would be helpful. We've just approved our corporate 3-year strategy, and this is the starting point taken from that strategy. So Berkshire is now rated as outstanding by the Care Quality Commission. We provide community and mental health services across the piece, and we provide inpatient mental health wards as at Prospect Park in Reading, as you'll be very aware. And then, oh, sorry, that's my dog. And then a range of community mental health services. If we move on to the next one. Are we able to move on to the next one, please? Thank you. This was the mental health strategy that we agreed in 2016, which I referenced would ideally have been coming to fruition, but for obvious reasons, we've had to roll some of these priorities over into 2021, and I'll be quite clear about that when we move on. Effective and compassionate help, working with service users and carers, access to services, collaboration, good experience of treatment and care, and supporting our staff. The vision, safer, improved service with better outcomes supported by technology. One of the outcomes of COVID has been a massive acceleration of the use of technology by a number of our services, and that includes quite a few of our mental health services. And it's really interesting. We do obviously virtual visits with our services, and our crisis team we're actually saying that because they've moved to remote consultation, it's actually improved the access to some of their services. So they will have fathers more easily engaged now with family conferences than they had previously, partly because they're working from home, so they're able to access, and partly because the new form of access, i.e. remotely, is more enabling for different groups of people to be accessing services that we previously had quite difficulty accessing. So that's a positive, but I'll be honest, it's you need to take into account that there are other groups of people that are finding it more difficult to access our services remotely. So whilst there are positives, we are very aware that the digital offer doesn't work for everybody. And going forward, we do need to go more to this blended model where we can provide safe face-to-face services and digital where clinically appropriate and safe to do so. We can pop onto the next one. This gives you an idea of what we call our roadmap. So this gives you, against Prospect Park Hospital development, what we expect to do in each year. Pathways work, which includes things like CAMS, zero suicide, where we wanted to get down to zero suicide on our wards, what we needed to do around urgent care, IAPT, and then longer term care, and I'll give you some bit more detail on some of those in the next few slides, please. So the impact of COVID on our mental health strategy, as I mentioned at the beginning, it has impacted. We were able to keep the vast majority of what we call our mission critical and high priority programs of work going, but the numbers of patients coming into our mental health services has increased significantly, and what we call the acuity, i.e. the poorliness of those patients, are much higher now. And some of this goes to Shona's point that people who might have accessed our services earlier on when they weren't in crisis are now much more poorly and in crisis once they hit our services, so it makes for a more complex presentation. All of the service changes we made were in line with national guidance. We have been able to provide a number of services on appointments online. Since March 2000, we've delivered over 50,000 remote consultations. And that's a positive, because if we didn't have that digital capability in place, that would be 50,000 consultations that didn't happen. So we are really proud of what we've achieved there. We've built a really comprehensive staff wellbeing service that is offered to all of our partners across the piece. And as I say, we were able to maintain a focus on our really important services and transformation projects. If we can move on. This gives you an idea of the changes in appointment types. So you can see the decline in face-to-face appointments. The green is the increase in online consultations, and the blue is the increase in telephone consultations. And you can see the difference for older people's services, as I was talking about earlier, not as necessarily comfortable with digital, but a lot more telephone consultations happening there. If we can move on. And then changes in referrals, unsurprisingly, the same sort of wave pattern that you've seen in the other slides that I shared earlier in the recovery pack. If we can move on. Progress on key initiatives. So we had, as I mentioned, a line for Prospect Park Hospital where we're looking at what we call bed optimization. So that's making sure that people are in the right beds, and that they're only there for the period of time they need to be, and they can be either escalated up if they become more poorly, or referred down when they start to get better. And they don't literally just stay in the ward. So that's been a programme of work that's continued. We had been really successful at reducing our out of area placements. COVID had quite an impact on that, and it's not just an issue for Berkshire, it was an issue nationally. At the height of the waves, we literally had no beds, and patients from Berkshire were placed out of area. Things have eased now, and we are bringing Berkshire patients back into Berkshire, but it does continue So it does continue to be an area of pressure, and you know the target we had of reducing having no out of area patients has been blown for 2021. In terms of staffing, we have a dedicated programme around recruiting staff in Prospect Park. We've done really well in recruiting student nurses, and I have to say they have been absolutely sterling. I mean, fancy being a student nurse in a pandemic must be, you know, really challenging. So they are absolutely great. Our talking therapies are now embedded in regular operational management and reporting systems. So the point there is that it's no longer a new service, it's about increasing the capacity of that service. And we have what's called a common point of entry. You might note as a single point of access for all of our community mental health services. And the idea there is that a person will phone, there'll be triage, and then they're signposted even onto the right services. There's no bouncing around different services. Serious suicide, I mentioned, will continue to be what we call a mission critical, a top priority project going forward. If we can move on. Pathways and clustering. Clustering, I know it's a bit of NHS jargon, but basically what that means is it's a bit like how you code patients. So you understand how many patients you have with severe dementia, mild dementia, with depression, with emotionally disturbed personalities. And the reason why that's important is so we can understand and ensure that we are putting our capacity and our nurses and our psychologists in the right place. It's also about making sure that we're delivering the right services for the cohorts of patients. The Emotionally Unstable Personality Disorder Project is about identifying those people who have personality disorders and then being able to provide them a therapeutic offer rather than putting them in a bed and highly medicating them. So it's working with them through therapy to try and get underneath what is that emotionally unstable driver within the personality. Structured clinical management is just the way we organise all of our community mental health teams, and of course we offer a range of specialist mental health services for people low and medium secure. We're part of the Thames Valley Provider Collaborative that offer those. There continues to be a focus on our community mental health workforce and how we recruit and develop that, and we continue to provide urgent care services throughout the pandemic. And as I say, we didn't stop the face-to-face for urgent or crisis services in mental health or community health going forward. If we can pop onto the next one. This gives you a bit of an idea of the impact COVID had on mental health. We did have an initial drop in activity, but it's now increased to pre-COVID levels again. There is greater percentage of more complex presentations. So people, as we were saying, a lot of people attending to turn up later than they would normally do. So they're more poorly when they do turn up. Early intervention is really important in mental health, in a lot of mental health illnesses. If you get in early, you can prevent a really major crisis later on down the line. But we are seeing more seriously ill mental health patients. And we are also, and this has been in the national news, so I know you all know this, we're also seeing a lot more safeguarding referrals due to domestic abuse. The national modelling is predicting up to 20% of the population will have a new or additional mental health support needs. That's significant. We know that there's been an increased anxiety, depression, trauma, complex grief. We don't know what the medium long-term impact is going to be of that. And that will impact on all of our services, I'm sure. And the impact is unequal. There are higher risk groups. It's well documented now the impact that COVID has had on Black and minority ethnic communities, care home residents, disabled people, and obviously frontline staff who are at the forefront of this. So the graph on the right gives you a bit of an idea of what's happening in terms of mental health activity. but it doesn't follow the line that you're used to seeing in terms of referrals, because there is exponential growth in mental health referrals. So it's not going down because the wave of COVID's going down, because of the multi-factors that drive mental well health as well as ill health, unemployment, insecurity, anxiety, homelessness. All of those are going to be with us for a while yet, and all of those are key factors in people's mental well health and ill health. So if we pop on to the next slide, that would be really helpful. This gives you an idea of the services that we're offering. We continue to offer talking therapies. We are very much working in partnership with others. The what we call the mental health gateway, that single point of access I talked about earlier, is there to designed to make sure that people go to the right service straight away. There's no wrong door. People don't get bounced around. All of our services and interventions are based on evidence-based approaches. Very keen to continue to work with our local communities. I've already mentioned the staff wellbeing offer and the increased accessibility by digital online. And then you've got some really, hopefully, some really clear examples of how the different digital and online offers have worked, and some examples of what we offer in terms of our staff wellbeing service. If we can pop on to the next one. Priorities for 21-22. In terms of adult mental health priorities, continue to progress some of the transformation plans I've talked about. The continued mental health investment standard continues to be a priority for Bob and Berks West, and we've been successful in securing some additional funding through that route. As I've mentioned, we're prioritising mental health checks for people with serious mental illnesses. It's simple things like we get people to stop smoking, exercise more. All of that will really make a difference to the life span of people with serious mental illnesses. Embedding our mental health pathways into NHS 111 to make sure that anybody who phones 111 is directed to our services and the right service at the right time. Really developing crisis and home treatment as an alternative to hospital admissions, and that's some of the funding we've secured through Bob. Talking therapies, really expanding the service, making sure that we put any inefficiencies we make back in terms of investment into the services. And in terms of CAMS, continue to support the CAMS teams. We have a major project on CAMS waiting times, getting help in the right place at the right time, reviewing the crisis service to ensure that young people who go into crisis get an appropriate response at the right time, maximise home treatments, have a home treatment service model. Really keen to have closer links with primary care and join up with connected care. I've mentioned website developments, the digital, such as the Sharon offer, which underpins CAMS, and then reducing the waiting times for assessment and treatments. The waiting times for assessment and treatments are growing at the moment. So this is because of the pressure on mental health services. So that is something we are trying to recruit additional staff to try and ease that as much as possible. And we had been very successful at recruiting to Prospect Park, so we are looking to try and repeat that way of working. In terms of eating disorders, we don't provide eating disorder beds ourselves, but we are aware that there are increasing referrals to the eating disorder services. These are provided by across Thames Valley, and for us they're provided by Ox and were provided by Huntercoo in Workingham. If we can go on to the next one. And this gives you some of the detail of the expressions of interest we submitted to Bob that we've been successful in securing. So we've been successful in securing some money to look at those alternatives to crisis. So we will be able to provide additional crisis services for adults and older adults, and look at alternative pathways. The model builds on voluntary and community sector involvement, focusing on priority inequality cohorts, peer support workers. So that's, you know, a real positive that we've been able to secure that. And we've been able to secure some investment to integrate our services with the primary care networks, which I think everybody would welcome. And then again, we've been able to secure some additional investment to look at how we strengthen the suicide prevention work through community-based prevention, targeted on on what we know are the local risk groups, middle-aged men, for example, people who self-harm, and people with learning disabilities. So I think the next one should say thank you very much and any questions. So I hope I've given you a really comprehensive overview of the mental health strategy, what we were aiming to be able to deliver. I hope I've been clear in some of the pressures we've had and the impact it's had on our services and what we're hoping to achieve going forward. Thank you. And I really apologise for the dog woofing in the background. Sorry about that.
It's part of normal life, Catherine, isn't it? Okay, thank you for that, Catherine. So I think we have got some questions. I'm just having a quick look to see who's put themselves up for a question. Here we go, Deborah Hunter.
Hello, thanks Catherine for that. Really interesting. I'm Deb Hunter. I'm the Principal Child and Educational Psychologist and Mental Health Lead in Brighter Futures. Just really wanted to emphasise the fantastic examples that you spoke of our multi-agency working. So the MHSTs that we're running with our CAMS colleagues, and the training for education for schools and other educational settings, and the development of the crisis pathway, which again has a real focus on multi-agency working together. One of the areas that I had noticed in your slides was about perinatal mental health, and again the importance of that early intervention to try and work downstream to prevent it escalating. And just to say, it's great to be working so closely with you. We're very keen to try and keep those multi-agency, multi-forums and opportunities going. But I think we need to make sure that we have regular communication to ensure that we are making bids together, for instance, that we're doing more planning together, just to keep the pace on that, particularly around the area of perinatal, for instance. And for me, two areas that I would really seek further involvement with, particularly our CAMS colleagues, would be around early intervention and identification of eating disorders, because we know that they're being really masked in schools, and the age of onset is getting younger and younger. And also children and young people with autism, with emotional well-being, mental health issues. Again, we see emergent research coming out, and I'd be really keen that we work together closely to try and put some of those initiatives into place across Reading. Thank you.
Thank you, Deborah. Any reply to that, Catherine, at all?
Absolutely agree. Really pleased actually that you've mentioned children, autism and ADHD. We had a really comprehensive conversation about that at our Quality Performance Executive Committee just recently, and there have been some really positive conversations with the clinical commissioning groups around what we need to in what we could potentially invest, either from a CCG or from Berkshire's own resources, to try and bring down some of those waiting lists, because they are far too long. So absolutely agree. But I'd be really interested to pick up, not now, but at some point in the future, your comment on regular communication and planning, just to make sure that we have actually got that in place, because communication and planning is so important when you're working with multiple stakeholders.
Thank you. Anyone else with any questions for Catherine? I'll throw one in whilst maybe some people are thinking about it. So Catherine, one of the concerns in past meetings has been about the waiting times for access, especially to some of the children's services for ADHD and autism assessment. Is there any learning from the pandemic in terms of going digital as to how to deal with that problem, or are we still in the same dilemma that there's still going to be long waits, or does going digital actually offer some solutions to some of the waiting times that were a problem previously for face-to-face assessment?
Yeah, it's a bit of a mixed answer, I'm afraid. So some of our services have been able to significantly reduce their waiting times because they have moved over to digital, and they've been able to. It's faster, because you haven't got, you said, professional travelling all over the county trying to visit people. So for some services it's worked very well, but there are other services, including autism, it doesn't work well because you need to do you need to have that face-to-face contact for assessment. So actually, for things like autism, it's not had a positive impact. It's actually had a negative impact. So there are some pathways that are available digitally, but my clinical colleagues will always say you can do some, but you have to actually do a face-to-face assessment. And that's the honest answer. It's worked great for some, doesn't work very well for others, and as it happens, autism is one of the ones that it doesn't work very well for.
Okay, thank you. Any other questions? I think no one else has got their hands up. So Catherine, thank you for that very comprehensive report. Some very interesting information in there, and thank you very much.
Thank you so much.
I'll let you get back to Doggy and make sure he's okay.
Thank you.
Okay. Right, I think we're moving on to, we're actually moving backwards to item 7. So this is the health of asylum seekers and refugees item from Health Watch. So Mandeep, are you talking to this item?
I am, thank you, Andy.
Okay.
I have no slides, so it'll just be my annoying voice, unfortunately.
Okay.
So you would have seen the report. So this report shows the experiences of refugees and asylum seekers placed in a Reading hotel as part of the government's response to the pandemic. The aim of this piece of work was to ensure that the residents' health and wellbeing needs were being met, the rights were being upheld, and they were being given a voice. Especially as we know from previous Health Watch work, the barriers to accessing services that this group particularly faces around language and communication, and not having a working knowledge about how NHS and care services operate. So once lockdown restrictions were easing, Health Watch got back out and went to visit the hotel on 4 different occasions. During those visits, we spoke to 43 residents who were from 19 different countries and spoke 16 different languages. They had been in the UK for varying lengths of time and mostly had been living in other parts of the UK before being moved to the hotel, although we did speak to, I think it was 7 residents who had been placed in the hotel directly upon arrival. Their status of asylum also varied, and that impacted also on their well-being. Their concerns mostly focused on dental issues, varying pain, medication supplies, mental health issues, and insomnia. Their move to the hotel in some cases has caused unsafe breaks in their care, in their ongoing treatment, and receiving regular medication. Other issues like having no money to buy things like over-the-counter medication just exacerbated their health concerns. A lot of this is best illustrated through some of the case studies we have in our report. So I'm just going to read one or two out to you now. So for example, we spoke to somebody called Mohammed, who's a 52-year-old man who moved to the hotel from London in April. Originally, he was from Africa and had a basic understanding of English. He told us he was a diabetic and had had no diabetic medication for the past month. He had been trying to stabilise his health through his diet, but he was concerned because he felt the food mainly consisted of carbohydrates like bread, rice and pasta. So he had not been eating well as well. He had been registered with a GP in London, but had no idea how to access his medication. So we worked with him to call his GP, who sent an electronic prescription to a pharmacy in Reading. And when we then called the pharmacy to ensure it had been received, and Mohammed got his medication and is better for it. Another example, we spoke to Farzad, a man in his 40s who's originally came over from Iran. He had no understanding of English and did not speak English, and he spoke to us via an informal interpreter. He had told us he'd had bad toothache for several weeks and showed us so. He had holes in his teeth, they were bleeding, and he was in a lot of pain. He had no access to pain relief and was limiting what he ate because he was struggling with solid foods. He was desperate and he did not know how to get treatment. So we made inquiries on behalf of Farzad, and we found out he had a HC2 certificate which entitled him to free dental care. He did not know what the certificate was or what it entitled him to, but we were able to help him with that. We rung a few dentists and one was able to support, but they couldn't provide an urgent on-the-day appointment because he needed interpretation. That took a further 2 weeks, but he hung on in there. Eventually he did go and see the dentist with some support, and he came back with his treatment and having to take antibiotics, but it was a long time before he could actually access the support he desperately needed. We generally supported residents with helping them to register with local GPs, make appointments on their behalf, ensure they have the right paperwork and access to prescriptions, as well as connecting them up with local services where needed. I think what concerned Healthwatch the most throughout this through this piece of work was the lack of timely, joined up and appropriate response to meeting their health and care needs. Once they had access to services, residents reported good and compassionate care, but it was getting there that was the issue. It was nearly 4 months into their stay that there was a mass registration to a local GP that took place. There had been no previous arrangements to support with prescriptions or ongoing medication or connections into care services. The residents themselves had already been taken away from their friends and their networks and suffered much trauma just into their journey into their UK. And their barriers around language and communication were really not fully appreciated. And those were some of the real highlights of the concerns that we found from visiting and talking to these residents and trying to get them the support they needed. I would like to say thank you to local charities and solidarity organisations who really did support residents at this time through meeting their basic needs, as well as supporting them with appointments, for example. And the hotel staff also showed great kindness to some residents at this time. And without the support, those supports of those organisations and the hotel staff allowing us to come in and encouraging and supporting our visits to the hotel, I'm not sure that the voices of these residents would have been heard and we wouldn't be learning these important lessons today. We requested that providers and commissioners answer some basic questions which are outlined in the report about the stay and arrangements for these residents. This was to highlight some of how the process had negatively impacted on them, but also so that we might learn some lessons. And I know that residents will be moving out of the hotel very, very soon. And I hope that some of the learning we've achieved through this report means that they have a more positive experience going forward into their next location. And that is really my short snapshot of the report. Thank you.
Sorry, I need to remember to unmute myself. Right, any questions? Maureen, yes. Would you like to come in, I think, from the CCG point of view?
Thank you, Chair. I'm Maureen McCartney. I'm Director of Operations and Urgent Care at the CCG. I'd first like to say thank you very much to Healthwatch for their report. It's a really comprehensive report, and all that you have done to support the residents of the hotel resolve their specific issues, many examples of which were in the report, and also more generally be an advocate for them. The CCG provided a statement in response to Healthwatch, and I'm sorry that it didn't address all of the specific questions. So there is something I would quite like to clarify, which is the issue of when the CCG was aware of when the residents were in the hotel and the arrangements for registration with the GP practice. So I do want to confirm that we first became aware that the refugees were resident in the hotel on the 7th of May, and we were then told that day that there were 61 people in the hotel and that they'd been there since the 2nd and 3rd of May, i.e. the weekend before. So our primary care team had a discussion with Clear Springs, who are the company that provided the accommodation, and were told that the residents would be looked after by the London Immigration Assessment Centre, and they were very likely to only be resident in Reading for a few days. So based on that information, we weren't aware that we were required to organise registration with a general practice for them. So on the 12th of June, the CCG had a formal letter from NHS England advising us that we needed to put healthcare arrangements in place for the residents. And we then sought clarification from the London Immigration Assessment Centre, who confirmed at that point they no longer had the capacity to do that. So 5 days later, on the 17th of June, the CCG arranged for the walk-in centre to register the patients. And I can also confirm that GPs from the walk-in centre went into the hotel 6 times to hold clinics for the patients and to do their best to respond to their needs. So I hope that helps clarify the position from the CCG perspective in relation to securing GP services for these patients, which is hugely important. And also I understand some of the patients chose to register elsewhere themselves, and also that a couple of them chose to stay with a registered GP in London. And then just to also add that we obviously worked with the local authority, BHFT, the Reading Refugee Support Group, and we're part of the weekly, twice weekly meetings. So I hope that's helpful, Mandeep and the board. Thank you.
Thank you, Maureen. Mandeep, do you want to respond to Maureen at all, or anything further you want to add?
No, thank you, Maureen. That does help clarify some of what we know, and I think there are bigger issues at play to this, not only just our kind of local responses, the fact that the residents had still been at the hotel for 3 months before an instruction was given to start to support these individuals is just not good enough for the care of people in our community. But the time frame you've highlighted is very helpful in helping us understand when those services were available to them.
Okay, thank you.
Okay, I think we've got a question from Shona Douglas. Shona?
Yeah, thank you, Chair, and thanks, Mandeep, for the report. And I think that we've had a conversation about, and you talked about the learning for the future, and I think that's the thing that we need to kind of take forward, isn't it? Because there's a wider issue here, and it is a set of complicated arrangements. And similar to Maureen and the CCG, we submitted our comments as you'd requested for us to do, and just to kind of flag, which is in the report in our comments, is around some of the complexities. And I guess one of the questions is really around just whether the report has been forwarded to the Home Office, the Immigration Office, or Clear Springs, because I think that's quite important that they're aware of some of those issues. But that the council did, as Maureen said, put in support and supported through the Refugee Support Group, and our housing colleagues were part of the group and attended and ensured that some of the issues that were raised were picked up. So the council was involved in trying to make sure that all the things that you're raising were adequately dealt with once we were all aware that these people were on our patch. And we've obviously got to be very concerned about people who are on our area and our patch. But it is just one of the things to point out that there are some slight complications around when we can and can't intervene in these sorts of situations from an adult social care perspective. And I think I've detailed that within the report. But I think the important part is is trying to pull out from the Health and Wellbeing Board what, you know, if this happened again, what would we do differently next time, and what would our actions be? And I guess that's probably for Health Watch, ensuring that Clear Springs and the immigration, because I think it might be something that's looked at in the wider sense, not just at a local level, but also with those organisations, to ensure, are there some issues we need to address, or some kind of matters that need to be kind of put in place in order to ensure that people are protected, who are the most vulnerable quite often in our society. And we know that who suffer because of the inequalities that have existed. So I just wanted to sort of add some of those comments which we've discussed, and just to ensure that we're clear that there are, you know, as you say, it's complicated, but it might be just helpful to know that the other two organisations are aware of the report and have had an opportunity to respond to that. And thank you.
Thank you, Shona. Yeah. Can I just ask, Mandeep, I presume that Reading has been had, and Shona may know this as well, asylum seekers in the past, maybe obviously not in these huge numbers that arrived into the hotel. So was this quite a unique situation, or have there been issues with asylum seekers in the past, or is it just this circumstance with a hotel, such a large grouping in one place, that then it sounds like there was a miscommunication, misunderstanding, and obviously a lack of care for the patients or the residents, some of whom would needed patient care, which is why some of the issues of your report come up.
Do you want me to answer from the
RBC? Yeah, Shona, that'd be helpful.
I think the issue that's kind of the nuance here is that these were people that were placed through the Immigration Service from the Home Office, so they were under different statutory orders. So there were people who had been, as I understand it, who had either come into the country, as that Mandeep said, some had come into the country, asylum hadn't been decided, or they were waiting to move on somewhere else, so it was unclear. But they weren't ordinary resident in Reading, they were placed by the Home Office. And so any intervention, if there had been any adult social care issues with regards to Care Act duties, such as an assessment of needs, that would have needed to have been, we would have needed to be requested to do that by the Home Office, because they were technically within the restriction of that. The only responsibility that we would have, which would override those rights, is within Section 42 of the Care Act, which is in relation to safeguarding. And I think that I'm not aware of this happening in Reading before. This was a lockdown scenario because they were using the accommodation in Reading. But I guess what we now know is that has happened. Not all of us hope we will not be in a position of lockdown in the future, but we do know that in Europe that is likely, and that we need to kind of prepare if there is likely to be another situation. The asylum seekers who are in the hotel now are now beginning to move on. But I guess it's about, should we be in this position again where the Home Office and the Immigration Service have that jurisdiction? How can we set that up to ensure that these things that Health Watch have picked up don't happen again?
Yeah. Mandeep, any thoughts on that at all?
I think it's a really good question, Andy, because I think, as Shona said, there is something about learning should this happen again. This was it's unique in how it happened, I suppose, and how the lines of responsibility lay. But it's not unique in understanding the experiences of refugees and asylum seekers and their access barriers. That's not new to our local, and I think all it's done is highlight that even more, that when we are supporting people who have those barriers, we have to think about services slightly differently, and they need that extra support. So I think there's one thing about, we know the barriers of these individuals, and could we have done more to raise that and say, this is what we need to put in place. But you're right, the communication wasn't there in terms of it being timely, it being joined up, so that there was a more timely response to these people knowing the issues they were facing. So there are lessons to learn, and some of that lies with the Home Office and the fact that, you know, what was communicated when. And the pandemic, yep, we didn't all know what was happening the next day. But I think those are my takeaways, is we understand these issues and we should be working harder to address those barriers. And we have learned something should this, you know, forbid happen again.
Thank you. as ever, a Health Watch report that certainly highlights a very important issue and has been very thoroughly done, and has brought a lot of thinking for everybody and some lessons learnt. And I think we should commend you on the report, and thank you. Okay, shall we move? Nikki, are you bringing me to order? We can't hear you, Nikki, very clearly.
Sorry, I haven't got my thing down.
Okay.
Shona asked a question about whether the report had been forwarded to the Home Office and Clear Springs, and I think your question came in before Mandeep answered that.
Oh, sorry.
Yes, I was just typing in the chat that actually I was just typing it in the chat.
Yes, the report is being shared nationally through Health Watch England. We shared a brief summary report also with them, so it will be shared with the Home Office and Clear Springs, but we only have the statutory powers to ask.
I presume that was strategist powers to
I
ask the local authority.
Yes.
Yeah.
Okay.
Yeah. That's why you've come to this board, and thank you very much. I think it's been well received. Thank you. Okay, shall we move on to last few items? I know we're past 4 o'clock. We want to try and get through. So integration program update. I think Bev, are you giving the update for this? Oh, you're on mute.
There we go. That's it.
Yeah, we can hear you now. Thank you. No problem.
Yeah.
Crack on.
So I'm Bev Nicholson. I'm the Integration Programme Manager for Reading, working across Berkshire West. So I don't know if anybody wants to have the report on screen, but it has been shared. So I will just run through the headlines, if that's okay. So the report covers 4 main areas that are covered by the Better Care Fund, which focuses on integration across Reading and Berkshire West. And the first one is NELS, so it's non-elective admissions. And performance against that target is well. It's doing really well. We've got a maximum target of 10,607 for the year, and we are currently at 7,803 as at the end of January. And the next target is the 91 days target. So this is a target that looks at people that are discharged from hospital, and then whether or not they're still at home 91 days after their discharge, and the services that are put in place to support that. Obviously, this measures against those services as well. But the target is 93% of patients who are discharged from hospital receiving reablement support, who are then still at home 91 days after their discharge. And the target is 93% for that. So we achieved 91% in September, but actually we've taken a little bit of a dip recently. We think mainly because of the COVID and leading into the next lockdown period may have had some impact on that, but we're looking into the evidence to support that. The next target was DTOC, which is delayed transfers of care. But since May, we haven't been measuring delayed transfers of care due to a request from NHS England. We are measuring discharge pathways. And so we come to that further down the report. So if we look at the charts that I've put in the report, they show our performance against those Better Care Fund targets. And we're doing quite well, actually, considering the landscape at the moment with the pressures of COVID. I'd like to just discuss a little bit about the discharge pathways, because they are now the measure that we're. Sorry, I'm just putting up my copy of the report, which seemed to have disappeared off my screen. I shall just open that now. Just to explain what the discharge pathways are, which I think would be helpful for the members and the public here today. Here we go. Okay, so we have 4 discharge pathways, and the first pathway is called Pathway 0, and this means that people come out of hospital, they go straight home from hospital, and they don't have a care package, and they don't require any additional support. The Pathway 1 is a discharge to a patient's own home, and possibly with some intermediate care and reablement services support, whilst assessments are taking place. And then we've got Pathway 2. So Pathway 2 is the discharge to a community hospital for people needing rehabilitation in a bedded setting. They might have a higher level of need in terms of their care. And then Pathway 3, the final one, is people who are needing to be placed in a nursing or residential home. And this could include patients who are either returning to a care home or are newly identified as requiring care home placement. And then there's a set of metrics that were agreed and signed off by the Berkshire West System Partners at the Rapid Community Discharge Steering Group. And these include a core set of 6 metrics. And they are that 95% of patients are discharged on the same day when they're declared ready to go and medically optimised. That 91% of patients are discharged back home on pathways 0 and 1. And that 75% of patients are discharged on pathway 0. So of that 91%, 75% of them are discharged home without needing any extra care. And then 16% of the patients discharged on pathway 1, 8% on pathway 2, and 1% on pathway 3, needing the highest level of care. And there's a chart here looking at the performance reporting which commenced in October against these metrics. So for the Q3 period from 1st of October to the 31st of December, it shows we're actually exceeding the target for pathway 0, but slightly below target on pathways 1 and 2. And actually for pathway, for the 91% of 95% of patients discharged same day. We haven't got a measure, we haven't got data for that yet, but that's being worked on. And there were actually 94% of patients that were discharged back home on pathways 0 and 1. So then if we go down and look at the impact of some of the local community reablement schemes. So these show that residential admissions after a period of reablement are actually still significantly lower than the target. So the target is no more than 116 in a year, but actually we're only at 18 at the moment. And although, you know, we had some assumptions around what the reasons for that may be, we don't have any data to support it, therefore that's not evidenced here. And then when we look at discharge to assess pathway into Charles Claw Court, which is a reablement service, the maximum that we expect there, or the minimum that we expect to be discharged into that pathway would be 18 patients in any given year. That's a minimum amount. And we're sitting just above that in terms of the trajectory at 19 on the projected target. And so not as many as we would have hoped. But then this particular setting did have an impact because of COVID, because there were a breakout of COVID in that setting. With staff and patients becoming unwell. And then there's some additional funding that we look at in terms of the Accelerated Integration Programme, and that funding was put towards reablement services for 2021. And we have seen an increase in the number of people receiving home care from that reablement service in the last 3 quarters when compared to the previous year. There's a bit of a dip in Q1, which is April to May, but that's to be expected with that was the onset of COVID and the lockdown period. So there's a short programme update here on some of the programmes that were in play over the last year, one of them being the Neighbourhood Care Planning Group. And out of that, a central Reading multidisciplinary team was set up, which is running well, and the aim is now to start rolling that out across the other PCNs in the district. There are 6, and in fact, we've started having some planning meetings already as to how we're going to roll that out and what that might look like in terms of the number of multidisciplinary teams supporting the primary care networks. The Reading Integration Board work plan was significantly out of date. I came into post in December, so we're now renewing that. And in fact, there was an in-depth discussion at our Reading Integration Board just this week. So there will be a new work plan that will be shared with the Health and Wellbeing Board in time for the July meeting. And we are engaging with other partners as part of that process, particularly voluntary sector, and our mental health and wellbeing partners. And then at section 7, we've got some community and stakeholder engagement and feedback. We're very keen to expand this further, and there are many ways in which we can engage stakeholders, and we're definitely looking into that as one of our priorities for our work plan. But we have some feedback here from the community reablement team, from people that they have delivered their reablement service to and have given their feedback. And there's significant satisfaction with the overall community reablement team service, with 96% of service users saying that they are satisfied with that service. And 73% of people saying that they felt more independent in respect of their personal care after exiting the service, and more independent in preparing food. There was 60% of participants that said that they felt more independent in being able to do that. In terms of independence in mobility, 69% of participants said that they actually felt more independent. And then confidence in terms of the community reablement team working with them, there were 98% of service users said they did feel more confident having the support of the community reablement team, and that the 96% said that they felt that the community reablement team staff were professional, which is really great news. But we are looking at expanding the opportunities to really engage fully with stakeholders. So that's really the bulk of the report. Does anybody have any questions that they would like to ask?
Yes, so thank you for that, Bev. Any questions? I've got one just to get the ball rolling. A lot of that looks like good news and good performance. Is there any particular area where you feel things could be a bit better, or that you're focusing on, or is it just generally trying to keep everything up to speed across the board?
Yeah, I think generally we're just trying to focus on keeping things up to speed, keeping the wheels on the bus, as it were, and making sure that, you know, we carry on moving in the right direction. There is a move towards hospital avoidance, admission avoidance, rather than the NELS target that we've had. So that will be coming up in the future. So we'll be looking at measuring that slightly differently. We haven't yet had the directions about that, but that will be coming shortly.
Okay, thank you. Shona?
Thank you, Chair, and thank you, Bev, for the report, and thank you for providing the data, and really pleased to see the feedbacks. I think we want to continue to ensure engagement and service user and customer feedback, because that's the way that we grow and develop in our approach to what services meet people's needs. So thanks for that. I guess there's just a couple of points. One is, yes, you know, you flagged, I was just going to flag the Charles Claw Court. They suffered from COVID quite severely, and naturally one has to close the doors when that happens. So I think there was probably an 8 or a 10-week period where, obviously, whilst COVID sadly worked its way out of the environment, where of course we closed to admissions and have only just released it on a very kind of careful basis, as we all do in those circumstances. So actually, despite that, we probably have done really well and probably would have over exceeded had COVID not hit them quite so severely. And I guess the other bit is Andy's question, which is a really well made question, because the issue is, Andy, that the guidance for the Better Care Fund isn't out yet, but we do need to kind of think of now looking forward is how is our Better Care Fund going to be kind of allocated as we move forward, and what are other priorities for that, and where does that fit with the West Berkshire footprint, and where does social care fit in some of that? So there are bits where we need to kind of review where we're at and look at the projects we've got in terms of how that will be allocated going forward, with a focus maybe on different things or the same things, but I think that those discussions need to take place. And I guess one of the things that I'm kind of hugely keen about, which Maureen will recall, which was really where we ended up with Charles Court, is around prevention of admission, and where we do discharge people, that we're not using a bed-based service, that we promote independence, and hence the extra care flats being a discharge to assess service from the hospital to promote independence. And I guess that, you know, one of the things that I'm hugely committed to is that prevention of admission. So what is it what services need to be in place with our PCNs, our primary care networks and our GPs and our district nurses in order to prevent and get in early? And that's probably an area we've got services that do that, but we probably some development around joining that up. So I guess I just wanted to kind of set that out on the table about some of the aspirations maybe that we would want going forward. I see Maureen's put her hand up, so I guess she might add to what I've said. So thanks for that.
Thanks, Jenna. Yeah, Maureen, would you like to come in?
Thank you. Just to add that to what Bev and Shona have said. So I think it's important that we look outside the BCF as well, and that we at Reading Integration Board think about what real opportunities there are for more integrated work between health and care in Reading, and specifically what we need to do together to help reduce the inequalities that we know that exist, starting with the inequalities that exist because of COVID. So I think that will be a key priority for us in the year ahead, as well as the statutory BCF requirements. Thank you.
Thanks, Maureen.
Thank you, Maureen. I was going to come back to that actually. The health inequalities particularly. Thank you.
So it sounds like we're in a good place to keep business as usual going well, as you say, keep the wheels on the bus rolling, but be prepared for the new challenges of the new BCF requirements coming forward. Okay, thank you. Amandeep.
Hi, thank you, Bev, for really taking the time out and really showing us some good examples of patient experience measures. And I have to say, it's really good to know that the reablement team in Reading, which continually is always of a high standard and receives good feedback, that actually through this period it has continued to maintain that level of service. And I think that's reassuring to local people. So it shows that even something positive can be used to reassure people that that service is being maintained to the best of its ability. So thanks for taking that charge. It's made a real difference.
Thanks, Mandeep. Lap it up, Beverly. That's praise indeed. Thank you. Okay, so shall we move on to the final item, dashboard, our health and wellbeing dashboard. Who have we got to report on that? Have we got Kim or Janet? Janet, thank you. Fantastic. Crack on.
Right, thank you very much, Chair. So this is the regular report which comes to this board, which shows the latest published validated data against national indicators for the priorities in our health and wellbeing strategy, and an update as to what's happening with the action plan. For the sake of completeness, we always bring the dashboard showing all of the latest indicators, but of course they're not all updated that regularly. So I do just want to highlight the ones where there has been a change since the report report has last been presented. And something else which I just wanted to draw people's attention to as well, perhaps anticipating some of the questions which you might get around this, when we present the latest published validated data, that is already a little bit out of date. And generally that isn't too big of a problem, but 2020 being the year that it was, a lot of people are saying, how much can we actually rely on data from 2019 in planning going forward, because there's been such a seismic change. I think there is still value in looking at those trends, but in paragraph 4.1 of the report, there is also a link to Public Health England's wider impacts of coronavirus tool, which is something which increasingly is being used to pick up some more recent, if in some ways less robust, data about the changes that we've seen. So looking at the individual priorities and where we have got updates on the data, first of all, in priority 1, which is around supporting people to make healthy lifestyle choices, we've got updates to the data around the NHS Health Checks programme. And as anticipated, the targets there were not met, that the programme was actually put on pause. Obviously, other pressures on GPs, focus on the COVID vaccine rollout. The pause is being used to look at how in future that programme could be more targeted on people at greatest risk. So trying to find and derive a benefit from the pause, so that that programme, when it resumes, which is something which is in the pipeline, will be more effective than it was previously. Turning to priority 2 on reducing loneliness and social isolation, we have some updated figures on the perception of users of adult social care in terms of how much social contact they have, and that showed a positive trend. Again, it is quite old data. We do expect to see something different when the 2020 data is published. But in the meantime, there has been a lot of activity around this in this area, huge amount of increased virtual offers, increased befriending support, identifying some groups that were missing from the offer previously, and developing that. So we've got a good basis from which to go forward. We've also had reports coming back, particularly from our third sector partners working in that befriending area, about people reporting higher levels of mental distress during lockdown, which is to be expected, and there's been quite a lot of work done to enhance the training which is available to people working in that area, so that there is more mental health skills, more mental health literacy, and also building the resilience of those volunteers, because actually they've had a much tougher time of it in recent months than normally perhaps. The next area where we've got an updated figure is around the numbers of people completing treatment for alcohol support. Now that number has gone down. One of the things that we do need to take into account is in 2020, our local provider took a very conscious decision not to discharge people from treatment in the way that they normally would, because they were conscious that there were additional pressures on people, including being isolated. So where some people would ordinarily have been marked as having completed their treatment and discharged, they were deliberately kept within the service so that there was an ongoing mechanism and route to support for those people. So that will have had an impact on the figures. Next area is around dementia. We have seen a drop in the diagnosis rates for dementia. To be expected, the memory clinics were actually suspended for a period of time to protect vulnerable patients. We're also lacking data around the Dementia Friends figure. So the Dementia Friends programme is an awareness raising programme run by local dementia champions to help a wide range of people understand what dementia is and simple steps that can be taken to make services more accessible and more welcoming to people with dementia. The Dementia Friends programme has continued. A lot of the local champions have been retrained so as to deliver virtual sessions, and those virtual sessions have been really popular. However, the central team at the Alzheimer's Society that monitors has been furloughed. So actually, although we do think we've done quite well in terms of our reach, we don't actually have the data to prove that at the moment, but hopefully we'll be able to pick that up going forward. And the final area where we've got an update is around screening. and actually we have met our targets around breast and bowel screening. A lot of effort went into reminding and encouraging people to continue to attend screening appointments, notwithstanding COVID and lockdown. And the screening services are now back to their pre-COVID levels of operation. However, when we do see the most recent data, the data that relates to 2020, we do anticipate that there might be some impact coming from that. Thank you very much, Chair.
Jeanette, thank you for that, and thank you for that update on the latest data. And yes, and inevitably there will be data issues from the measurements of what's gone on from March, probably from March 20 onwards. So we're going to have a very strange year of data, won't we? Which we'll have to try and understand and in brackets put pandemic for any data for that bit. Thank you. Any questions from anybody on Jeanette's presentation? If not, thank you very much for that. It's useful to get the updates of anything that's got new data, because otherwise we lose it. So we're down to the last item. So the dates for our future Health and Wellbeing Board meetings are, the next one is on the 16th of July. I'm just going to quickly throw out for any last minute desperate questions anyone's got. If not, no one's throwing their hand up in the air. I'd like to say thank you very much for everybody who's attended this Health and Wellbeing Board. On behalf of the chair, Graham Hoskin, who had quite rightly gone off to get his vaccination, and myself, I wish you all to stay well, get your vaccinations, and we'll meet again in July. Thank you very much.
Thank you, Andy.
Thank you. Bye.
Bye.
Thank you, everyone. Bye-bye.
Thank you, Andy. Bye.